Hi, welcome to the Clinical Liver Disease Multimedia Journal author interview series. My name is Kim To, and I am one of the assistant professor at Yale University. I am joined here today with Dr. Elizabeth Richardson and Dr. Sana Arastu from Thomas Jefferson University to discuss the article Pro-EGD is preferred modality to screen for the diagnosis of esophageal and gastric varices when the diagnosis of cirrhosis is made. Thank you for your time and your discussion here.
Thank you for having us.
Thank you so much for having us.
No problem. So can you guys discuss the advantage in doing like a cost effectiveness and also the clinical advantages in doing endoscopy for variceal screening?
Sure, I can talk briefly on that. I think the clinical advantage of doing an endoscopic variceal screening is that endoscopy both diagnoses and treats the varices. You're able to see endoscopically if a varix has stigmata of recent bleeding, if it needs to be banded. And with non-invasive techniques, unfortunately, you're not able to treat a high-risk varix the way you are in an endoscopy. From a cost-effective standpoint, some of the research that we found was that you have to also understand in the healthcare industry, looking at prevalence of esophageal varices, looking at the overall health cost. You can't just look at how much does an endo cost versus how much does a non-invasive modality cost to the healthcare system, because not every single person on the planet is getting an endoscopy, and not every single person on the planet is getting a non-invasive modality to look at their liver stiffness. So looking at the prevalence and looking at the overall cost, the cost of a variceal hemorrhage based off of the prevalence of the disease is actually much more costly than just screening everyone with an endoscopy. And that is what some of the data that we found and were able to kind of extrapolate and use to our argument.
Yeah, it's actually very interesting because I think when we all think about it, we always think that, doing an endoscopy is really expensive, but that data obviously shows something different. How do you think this article is going to really impact our daily practices on a day-to-day basis?
I can answer that. So in terms of the impact on daily practice, I think, really truly in clinical practice, I think the good news about both sides of the argument is that it does provide patients options. So meaning, I think it gives us the opportunity to have a discussion with our patients now to say that, upper endoscopy has its advantages because we're able to both diagnose and treat. But if there is a patient that has a particular, aversion to having a procedure, then this is an option for them. And I think that in true day-to-day clinical practice, this is something that you might be able to go back to say about a patient that for one reason or another, it's not an ideal time for them to undergo a procedure. But truly, we do stand by the argument that the gold standard, which is what the question is asking for the diagnosis of esophageal varices, is upper endoscopy. And, I think Sana and I, we just wanted to emphasize, as she has mentioned earlier, there is a difference between the upfront costs versus the back-end costs of varices in general. When you're talking about how much does just a fibroscan cost versus an upper, but how much does it cost to miss something? And those costs are much greater than just a upper endoscopy versus a fibroscan.
That's a really good point. And can you discuss some of the potential pitfalls in non-invasive screening modalities?
So it's a very good modality in terms of screening for fibrosis and understanding a patient's baseline liver disease for sure, but really using these non-invasive modalities to diagnose patients with portal hypertension and esophageal varices really is still an area of study. And truly, when you do review the literature on this, there's some debate about what your cutoff thresholds are. So that's one of the drawbacks, is that just really, we have the Baveno criteria as a good working base, but this is still an area that's under research, and it does require some additional verification. And I think, as we move forward, we're going to be looking at different data points for different types of liver disease. Cirrhosis is just not one type of disease. It's very varied in terms of patients and etiologies, and there may be some differences there that we will learn in the future. And so all of this coming together just points to that there is some uncertainty and requires further research.
And I think you guys pointed out very astutely in your article that, you know, not every facility has the capabilities of doing non-invasive screening modalities. Like most places have endoscopy, but not every place has a FibroScan as well. What did you guys think was the hardest part arguing for doing EGD for varicose screening?
I can answer that question. I think one of the hardest parts for arguing is, you know, in today's day and age, everyone is focused so much on non-invasive modalities, new technology, and updates in how to treat patients. And I think Liz and I agree that FibroScan and these non-invasive techniques, all of them, MRI, elastography, they're all great advancements in the field of hepatology. But I think going back to the bread and butter of what we've learned to do is that endoscopy helps us diagnose. And I think one of the points arguing was that diagnosing someone with an elevated liver stiffness doesn't necessarily mean that a patient has cirrhosis. So if you read between the lines in all of these guidelines, what I think a lot of people are trying to say is we want to diagnose more people with liver disease. And if we're diagnosing more people with liver disease, we're reaching a greater population of those that would benefit from an endoscopy. Because someone might not have a nodular liver on ultrasound, but they have abnormal LFTs, they have low platelet counts, they're referred to a hepatologist or a gastroenterologist for a different reason. They end up getting some type of liver stiffness evaluation that says they have an elevated liver stiffness, which then gets them to the next step of meeting criteria for an endoscopy. And I think arguing that point is actually one of the harder points, which is what we're trying to prove, that we are actually getting more people eligible for endoscopy to diagnose and treat them with varices, as opposed to a smaller group of people that just end up having a nodular or cirrhotic appearing liver when they're referred to a specialist.
Well, Dr. Richardson and Dr. Arastu, thank you for the discussion. For our viewers, please don't forget to visit our website at Clinical Liver Disease to look at the article, and follow us on Twitter at CLD Learning. Thank you very much, both of you guys.
Thank you so much. It was a pleasure.